Good evening, ladies and gentlemen. My name is Hikmet Kadiroglu, and I'm a fifth-year medical student at Istanbul University, Cerrahpaşa Faculty of Medicine. I'll try my best on this exceptional event of CTF talks. I'm so excited to be here tonight and to have the opportunity to introduce our wonderful guests. Our first guest is Dr. Francesca Rubulotta. She obtained her MD in Italy in 1998. She became an anesthesiologist in 2002 and later an intensivist in 2004. She is currently working in the UK as consultant in intensive care medicine and anesthesia at the Imperial College, Charing Cross and St. Mary's Hospital in London. Dr. Rubulotta was a member of Division of Professional Development of the European Society of Intensive Care Medicine and Deputy Editor-in-Chief of Patient-Centered Acute Care Training Program. Currently, Dr. Rubulotta is Chair of Medical Managers, BMA Council member, and V of Council of Royal Society of Medicine, and COM of Education and Faculty of Imperial College Medicine. Dr. Rubulotta is also an avid researcher, and she studied 5 different languages. Our second guest is Dr. Lorenzo Ball. He obtained his MD from University of Genoa in 2012, and his thesis was low-dose quantitative lung CT, a tool for the optimization of protective ventilation in a patient with ARDS. Later, he became an anesthesiologist and intensivist in 2016, and his second thesis was intraoperative ventilation, recruitment maneuvers, and incidence of postoperative complication in obese and non-obese patients. Recently, Dr. Bol completed his PhD at University of Amsterdam with his work on optimization of mechanical ventilation, lung imaging, and intrapulmonary drug delivery in operating room and intensive care patients. He is currently an intensivist and a researcher at University of Genoa. He attended various courses during his career. He speaks French and English. And our last guest is Dr. Oktay Demirkiran. He obtained his medical degree from Istanbul University, Istanbul Faculty of Medicine in 1989. Then he completed his residency at Cerrahpaşa Faculty of Medicine, Department of Anesthesiology and Reanimation. He is a former representative in European Society of Intensive Care, and he is currently member of Executive Committee of Turkish Society of Intensive Care and Advanced Life Support Director of European Resuscitation Council. He is the Director of Emergency Intensive Care Unit at Cerrahpaşa. Dr. Demirkiran gives various lectures and courses at his faculty, and without a doubt, he is one of the key people that train newer generations of intensivists in Turkey. P.S. He is also a very popular professor among students, also known as Dr. Oktay. On a final note, they are all fascinating individuals, and we are grateful for their presence among us today. Without further ado, please join me in welcoming Dr. Francesca Rubulotta, Dr. Lorenzo Ball, and Dr. Oktay Demirkiran. Okay, so before we begin our discussions, our guests will present a slideshow about their COVID-19 stories in their country. Hopefully, this will allow us to have a deeper look for our upcoming discussions. After that, we will have 2 different parts in our total meeting. In the first part, we want to focus on morely medical issues surrounding COVID-19 pandemic exactly. And then, in the second part, we would like to talk about paramedical issues surrounding COVID-19. So, before taking this speech too long, let Dr. Francesca Rubulotta start with her slideshow and let us know all about the UK's story.
Thank you so much. So pleased and happy to be here and for your invite. I would like to thank the Turkish Society and all my friends to be there and for the incredible introduction. I have no conflict of interest, and I will be very happy if you want to follow the conversation on Twitter and maybe ask questions if we will not be able to cover all the interesting topics during this webinar. COVID has been definitely a unique experience and has driven a lot of attention towards intensive care. And this is probably one positive element of these difficult times. And probably you remember at the beginning of this pandemic, the attention was extremely focused on investing at all levels in buying new ventilators. As per the ventilators were able to fly without the pilots. Later on, we realized that this was not the case, and probably you are already familiar with those images coming from the hard work of nurses and colleagues all over the world. We sadly know that several doctors and several nurse and healthcare professionals died in the course of this pandemic, and sometimes death for these people was highly preventable. In terms of timelines, I'm very pleased to be here with Dr. Ball, because I think the experience in England and in Italy is comparable, and even the timeline is closer than we believe it is. In fact, the first case in Milan was documented, or the red area started around the 20th of February 2020, and my first case at Imperial College was detected on the 9th of March, having been in hospital already 12 days. Clearly, there is an overlap, or at least a very close timeline between the two countries, and that hopefully will make the discussion interesting. These slides will show you the trend of the disease and the spread of the disease. You can see likely we are in the descending part of the curve, but at the time of the ascending part of the curve, the response of the government was very determined, in the sense that they increased the capacity of the unit from 22 beds up to 60, and required from intensive care colleagues to look after up to 60 patients. Likely we never reach this point, but we had to prepare for this extreme workload. And as you know, I think that intensive care, and in particular mechanical ventilation, is very close to the experience of flying an aeroplane. We take off when we intubate the patient, but this is nothing. It's just the beginning of the journey. Lots of the effort is made by maintaining the flight and landing. And landing for this patient is not easy. It takes a long time, and the reintubation rate for most of the COVID patients is double what we see in normal patients. And also the environment is to change drastically. That means that we had to work on PPE, and you need to work in isolation. We needed to train and using those devices. We needed to change the way we record and our drug chart to make possible that none of these elements were coming at the bedside, because pen and paper chart can increase the spread of the disease. We also needed to train to use video laryngoscopy, and people might not think that COVID patient actually, even at presentation, might have a swelling of the airways and then cause some degree of difficulties. We did training for intubation, because communication is very hard wearing PPE, and we needed to get checklists that we used before entering the room and after entering the room. We had an intubation team made of experienced people, 2 anesthesiologists and 2 trained nurses. And with it, we still faced 48% of complication on patients intubated by the intubation team. We also did simulation related to transfer, because it's very difficult to transfer those patients from the emergency department to the ICU without contaminate. You do this going in the ward. So it's very difficult because you don't know the people you are working. So you might be in an environment which is not familiar. We had to increase the use of technology, because you will see that COVID might bring you to some challenges. This is a thrombus. And we needed to change our anticoagulation technique. We needed to introduce a lot of technology we were not using, and these include the beads and the bed ultrasounds. We will talk, I'm sure, about ECMO, and the criteria for ECMO were also different at the peak of the pandemic. Now we are normalizing the requests because we are in the descending part of the pandemic. But I think one of the biggest achievements at Imperial College is that we created very early on a treatment guideline group, which was multidisciplinary, and that helped in the long term to decide which medication to use. And I'm sure that we will talk about drug and protocols. We are trying still to find a meaning for inflammatory markers. We have a series of controlled trials. We can discuss that later, but effectively, we are now using those medications and we need to rationalize the use based on the available stock and the other needs and necessities. For instance, anakinra is used by the pediatric department and we cannot afford to use this only in the adult population. I want to conclude with the last two slides, and these are also interesting points that we can pick up in the discussion. The first one comes from an anxiety questionnaire that we run in 76 countries, showing that people are not worried in the front line by the incidence of the disease in the country. They're more worried by the lack of PPEs or the lack of clear information. What about non-COVID patients? This is another questionnaire that we did, and that matches a lot of other discussion that you can find in the literature, suggesting that there's a lot of ethical issues related to the fact that we use most of the resources to COVID patients, and now we need to face what in the long term will mean to cope with the requirement of the global population. I'm sorry I went 1 minute over my time. I hope this is gonna be good to trigger the discussion, and I thank you so much for your time.
Thank you so much, Dr. Rubulotta. I mean, this was a brilliant presentation. Thanks again. And now we can continue with the slideshow of Dr. Ball. We are all yours.
First of all, thank you for the invitation and for the kind introduction. I will start shortly the presentation. First of all, I would like to explain that this will be a brief presentation just to present some of the aspects we have observed during the COVID pandemics in our center, which is in Genoa, and I will show you where this city is located. Concerning the agenda of this presentation, we'll start with a brief discussion of the Italian outbreak, which you know is one of the most affected countries in the world, and the role of respiratory support, the role of the drugs that we have been using in the ICU, and we'll try to draw some conclusion. This is a map of northern Italy, and this is the region where I work, which is Liguria. It's a small region, very close to Lombardy, which you might know is the most affected region of Italy, and the place where the first cases were recorded. I will not show epidemiological data, but you might know that we had a very high number of deaths. We peaked around 1,000 deaths per day during the worst days of the epidemics. And things are improving a lot, but I will focus more on what we did in our hospital. We started admitting our first ICU patient on February the 29th, of course, during nighttime, as all the major problems typically occur. And one of these guys is me, and I cannot even recognize myself because we were all clothed with personal protection equipment. And fortunately, in our hospital, we did not experience major shortages of personal protection equipment, which was a problem reported by many other centers. Our hospital is a large teaching hospital, and what I think is really interesting is showing how we reacted to the increase of critically ill patients, because normally our hospital is structured as shown in the slides, with 26 general ICU beds plus other surgical ICU beds, step-down unit, and cardiac surgery ICU. Very quickly during the first phases of the epidemics, when we understood that things were rapidly getting worse, we tried initially to reserve only 2 places for COVID patients, leaving the rest unchanged. But we quickly realized that this would haven't been enough. So we increased again the room for COVID patients. And at the end, we ended up with having 27 COVID beds in our units. We opened the first satellite units with other 12 beds, and then we created a brand new intermediate care unit with 60 COVID patients. And again, at the end, we created the post-extubation ward for 8 patients after the ICU. I'm very happy of saying that the 3 latter emergency places were recently closed, so things are really improving, and our 27 beds ICU is no longer full, and the last admission is from several weeks ago. In total, we treated more than 100 intubated COVID patients because we decided to leave the CPAP patients in lower intensity areas of the hospitals. And we had lots of cases in low and intermediate care setting. Our main challenge was that we were facing, and Italy was was the second country in the world experiencing such a high number of cases. So typically oriented towards evidence-based medicine, we faced the problem of not having evidence on which we could base our treatment. And so we did a lot of physiological reasoning to try to understand what could be done for our patients. Unfortunately, Italy was hit so rapidly and so strong that we didn't have the energies to plan large randomized trials. But we hope we managed to contribute to with the world scientific community, because we discussed a lot with colleagues from all around the world and tried to share our experiences, also to guide the randomized trials which are now being run in Italy and in other countries as well. Concerning ventilatory support, one of the first issues we were facing was the high request for non-invasive ventilation, in addition, of course, to the request for invasive ventilation. And the shortage of devices was so high that we used in several centers diving masks that were readapted to become CPAP devices, with the use of 3D printed adapters to connect filters and PEEP valves on these masks that were kindly donated by the manufacturers. Concerning the role of invasive ventilation, there have been a huge debate on the role of PEEP, and we did in our center several studies based on CT, which we hope to publish in the next future. And we have seen that probably the use of very high PEEP level gives a very little advantage in terms of recruitment of lung tissue, and that probably several subtypes or phenotypes of this disease can coexist, and severe impairment of oxygenation can be seen in patients with milder CT scans with mostly ground glass opacities alone, and also in patients which develop an ARDS-like disease. But we are still discussing whether we should consider this a real ARDS or a separate illness, because there are many differences with conventional ARDS. Also in our case, we used the bedside lung ultrasound, but we had the chance of having a strong collaboration with the radiology department that allowed us to perform a lot of CT scans that taught us a lot about this pathology. Concerning the drug, there are probably several stages of the infection which might benefit of different drugs. And we used at the experimental level most of the drugs that have been already mentioned by Francesca. We also had a role in collaboration with other centers in Italy in underlining the potential role for cheaper drugs compared to tocilizumab and remdesivir, which are steroids, which we are using widely in Italy, also in non-severe patients, and we invested energies also in planning randomized trials. One of the first things we noticed, and finally there are reports published by Italian and other international groups concerning the alteration of coagulation in COVID patients with severe impairment of clot formation, as you can see in this thromboelastogram. And we decided to monitor closely the D-dimer to titrate the anticoagulation protocol. We used enoxaparin or low molecular weight heparin every 24 hours in patients without high risk for thrombosis, but we increased to therapeutic dose or even to sodium heparin continuous infusion, because we have seen a lot of pulmonary embolism and also clots in the venous system in other organs. But also we have seen another side of the medal, which is the bleeding in COVID patients, which we are now observing that it's probably not only related to the anticoagulation, because we have seen several patients bleeding without high dose anticoagulants, and typically in the later phases of the disease. Again, I mentioned to steroids, which have been recently shown effective somehow, but in retrospective data, while randomized trials are still ongoing. But I would say that in Italy, there's quite a common opinion that we should investigate steroids much more closely, because we think they might be effective and also cheap and so widely used in other settings. We also focused on the follow-up of our post-ICU patients, because we have seen that the CT scan you are seeing on your screens now is not the CT scan of a critically ill patient, but is the CT scan made 3 weeks after extubation of a patient which was apparently healthy and ready to be discharged to home. And this is the severity of the involvement of lung also after critical illness. So our suggestion in the most dramatic phase of the disease was also to stop and think, to try to spare some of our energies. We do a lot for our patients, but we also need to use our brains, because we need to understand much more of this illness, which is changing our lives. But in the end, we had also several good satisfaction from our jobs. We must consider that COVID-19 is a new pathology, so many things are being investigated. We know more and more every day, but so far we cannot do anything else but being prepared. And we must remember that there are no magic bullets so far. There are no proven drugs which are effective, and so we are still in need for new investigations and research. And again, our message is to think and try to understand more about this pathology, and to do it for our patients that fortunately in many cases can recover and restore their lives.
Well, thank you so much. It was a great presentation. Thank you. So I don't know why we don't see Professor Demirkiran, but we will continue with his slideshow. Okay, I think we are good. We are all yours, Professor Demirkiran.
Yeah, okay, thank you. Okay, could you see the slides now?
Yes, everything perfect.
And in Turkey, sorry. Is it clear to see now the slides? Sorry. Okay.
Yeah.
Yeah.
You're good to go.
In Turkey, in Cerrahpaşa, we organized our hospital for COVID virus attacked when we saw there will be a problem for all of us. In that time, yeah, the first case in Turkey was in 11th March, and then in Cerrahpaşa we planned our organization. We are get ready to this viral attack. We planned to divide our hospital for COVID positive and COVID negative patients, and the wards and the clinics transferred to COVID wards in our hospital. The elective operations canceled in that time, and we think about it, we need more ICU beds in our hospital, and then we change our theater to as an ICU. We supplied with the ventilators and the monitors, and we need more and more, and we had them, and we opened new beds, new ICU beds, and we start for give care for our patients. In Turkey, intensivists and anesthesiologists are the main part of this viral attack, because the severe cases must be in ICU, and we have a very good number of well-organized people, anesthesiologists, because they can give care in ICU in intensive care. Also, emergency medicine, infectious disease practitioners, the chest medicine practitioners, and the other specialties are very well organized in our hospital. And in Turkey, also the hospitals, most of the hospitals changed to pandemic hospitals, and our government built new 3 hospitals, each has 1,000 beds for pandemia. And we check for our protocol to treat this patient like in the other countries. We follow as look like this same the protocol. Our healthcare ministry published the protocols, and we use the protocol in our hospitals. Hydroxychloroquine at the beginning, azithromycin, we used it, and after hydroxychloroquine, if the patient need to be in ICU, in that time at the beginning it was in ICU, to use favipiravir, hydroxychloroquine, azithromycin, and we checked that there is a very severe problem with the coagulation, as Francesca said, and we change our anticoagulation protocol to prevent this, and we use anticoagulation for our patients in that time. We also add some other treatment facilities in our protocol: high dose vitamin C, vitamin D, immune plasma therapy, stem cell therapy, dipridamol, and the other treatments like ECMO. I will tell about this in a few minutes later. This is like a protocol in other countries, and we have our own protocol in Cerrahpaşa, and we use it. There are some pictures here which are very interesting. That this is a huge corridor for the theater in Cerrahpaşa, but you see that the theater has been changed as an ICU now. The old rooms has 3 beds in one theater, and we have at least 20 theater, and we use more of them for our changing into ICU in our hospital. You see here the beds, like ICU beds here, the patients with COVID virus pneumonia infection here, they are in prone position now, you see, like that. And before intubation, we used helmet mask for them, the non-invasive techniques and nasal high flow techniques. When it was failed, then we intubate the patients. We use the all personal precautional equipments for intubation. We wear all of them. As Lorenzo, you said, one of the patient was you, and that was me. you can recognize me here, but I'm intubating the patient. We use this, and we have enough equipment in our hospital. And we use more advanced techniques like ECMO in our ICU, and we use it in our intensive care unit for our patients. The cardiovascular surgery help us for using this, and we both manage these patients in our intensive care units. And we also use CRRT if there is acute kidney injury in our patients, and we have enough machines in our ICU. This is one of the scene in our ICU. They're giving care for the COVID virus infection diseases. The intensive care beds is the rate is very high in Turkey. You see that in US it is 34.7, in Germany 29.2, in Turkey it is 20.1. It's a good number to have ICU beds in our country, and we don't have any problem with the intensive care beds in country. But in Istanbul, most of the cases were in Istanbul and still in Istanbul. And the problem was in Istanbul to have ICU beds, and we increased the ICU beds in our hospital because of that. This is a war, and the intensivists are the main coronavirus, I think, and we fight with this virus, and we have to do we do all for this in this fight, because this virus has different phases. We don't know this virus. How does it do this, and how can we stop it? Because all medications are not exactly specific for this virus. We try to use it and try to get some help for the medications. The virus has masks, has different changes every time, and we have to be careful. We have to be careful with this virus. It's hard to fight, but not impossible. And we have a motto in our faculty: if you need me, I see you. Really, if you need us, we are in intensive care. We have to stop this. We have to stop the virus, and we fight this virus. Thank you.
Thank you, Dr. Demirkiran. Now we may begin with our discussions. I would like to start with our first question. And the first question will be about points during the COVID-19 stories of each country. So for most of the news, the breakpoint for UK was herd immunity, and then UK suddenly changed this strategy, right? And today, I think the Prime Minister of UK announced that now UK will begin to track the coronavirus people in the whole England and UK, probably beginning with the 1st of July or June. I'm not very sure. And this is the main question for you, Dr. Rubulotta. Why do you think herd immunity was the first strategy for the UK? And when UK decided to leave this strategy? And for Italy, Dr. Bo, most of the correspondence letters from prestigious journal websites, most of the Italian authors suggested that Italy faced such a huge infection because there were problems with the quarantine measures being late. And also the hospitals were quickly overwhelmed with the infected people. So why do you think Italian government or why Italian people took the quarantine measures a little late. And for Dr. Demirkiran, I would like to ask, like, Turkey managed to keep COVID-19 behind its borders for a very long time. I mean, most of the countries faced COVID-19 cases before March, but Turkey faced its first case in 11th of March, if I'm not wrong. And how did you achieve that? That's my first question. Now we will begin with Dr. Rubulotta, and then we will turn back to Dr. Bol, and we will continue with Dr. Demirkiran. We are listening to you, Dr. Rubulotta.
Thank you so much. Thank you so much for the questions. So I think what I learned today through the presentation of my colleagues is that we were very close to each other. So the first case for Lorenzo was on the 29th of February. My case was in hospital and detected on the 9th of March. And I think in Turkey, the first case was on the 11th of March. And I find really interesting how action and the lockdown time has been so different across countries. And I see this as a failure where actually decisions were made outside the scientific world. Regarding this approach, there are interesting publication which I added at the end of my presentation, where actually the fact of not moving together globally has been seen as a weakness, where the possibility of lockdown at the same time could have prevented further spread. And I think this is a lesson we learned and we were not aware of before the pandemic. And it's an important lesson we need to keep in mind for the future. And I brought up these slides just to show you that this is the situation that we are seeing around my hospital. And I don't know whether you can see my arrow, but it seems that the lockdown, even if started significantly late compared to Italy, has had some benefits. Now the problem is, what will happen if we open the schools? So how is infection mediated by kids? There's some advice suggesting that the viral load is lower in kids, or the infection can be contained if transmitted by kids, but this is all, according to me, based on assumptions. And the second is, when can we restart surgery and care for non-COVID cases? So I think we potentially made a mistake starting at different time to adopt the same strategy. Maybe we were not vocal enough as scientists to overcome the needs of the economy, of the politics. But now that we need to go to phase 2 and open up, how do we move together is my questions. And how do we not make the same mistakes? I hope this is an answer.
Yes, thank you so much. Thanks. And now we are listening to Dr. Bol.
Well, concerning the strategies adopted in Italy, I think that the main explanation of the severity of the spread in our country is that probably the virus was circulating in the community much earlier than we think. And there are studies now suggesting we tested blood donors samples in the month of January in the most hit regions of Italy, discovering that in early January, when we thought that the virus was confined to China, in some areas we had a 20% prevalence, 10% prevalence of positive antibodies against the coronavirus. So probably our major problem was that the virus was much more advanced than we thought. We probably missed several early cases because to see severe cases, you have to have a lot of cases, because we must remember that in most patients, the disease is very mild, and only a small percentage of of people develop the severe form. So probably before noticing coronavirus, you have to have a lot of cases in the community, unless you don't test the population in a very systematic way. So probably our mistake for sure was starting the lockdown too late, but we must also remember that we were the first country to be hit after China. So we did not know almost anything about the virus, and we severely underestimated the problem. I don't know whether it's a fault of anybody, but I don't think it's yet the time to make this kind of reasoning, because we are still in an ongoing emergency and we don't know how this will evolve. So I think that other countries reacted better, and that other countries probably were only more lucky because they had fewer cases and possibly also fewer commercial ties with China. For example, northern Italy, which has a high density of industrial activities, has very strong ties with China. And this, I think, might be one of the factors explaining why we were the first and why we were so hardly hit. And I hope that our sufferings and our lessons can have given some help to other countries in preparing better.
Exactly, it did, for sure. Thank you. And Dr. Demirkiran.
Yes, we have like the same scenario also in Turkey, but we are get ready for this viral attack because we have some examples before the virus attacked our country. And we know that this will be very bad for all of us, for our country, and we have the precautions before we have severe cases in our country. The government and the healthcare Ministry of Healthcare organized before we attacked this virus, and in that war, I say war for this. In that war, we were very we prepared, very organized in that system. And why we don't have more severe cases? Because we stopped the people in the field. They stay in their home still. They stay in home. We stopped the working hours. All facilities stopped. The flights stopped. The transfer stopped, and the schools stopped. You know, the kids are in home, and everything has stopped. And we keep them in their home, and we prevent the spread of the virus as we can do this.
Yeah, thank you. Thanks. Now the next question. Okay, also Dr. Ball mentioned in his slideshow, we didn't have a centralized guideline during this pandemic. Every country or even every hospital had its own kind of guideline to manage this pandemic. So I would like to ask, how did you, I mean, could you answer in briefly, how did you define a mild, a moderate, and a severe COVID cases? When did you hospitalize them into ICUs? And how did you approach to them? And I mean, like, when did you apply the ECMO? When did you give them the tocilizumab or other treatment modalities? And also, as Dr. Ball mentioned in his slideshow, most of the countries managed to increase their ICU bed capacity. But we would like to know, how did you do this? So we can continue with Dr. Rubulotta.
Thank you so much for these questions. So the definitions of moderate, mild, severe is, I mean, a common definition. The problem for us is mostly related to triage. And this is a hot topic because several publications came out to guide intensive care doctor on how to define the patients that will benefit from intensive care compared to those that will not benefit. And this was related not just to the severity of the disease, but a series of different components. And obviously, higher was the pressure on the institution, and harder were the decision made, I suspect. And I think, in fact, and probably Lorenzo might comment on this, Italy, the Italian Society of Anesthesia and Intensive Care produced one of the first guidelines, which was highly criticized, but inspired lots of other countries to develop their own guidelines. And for instance, you can see to ANZICS, or now we have in England some tools for triage. The United States came out with a series of an interesting paper, given the fact that, as you know, the healthcare is private. So there are a lot of ethical questions and legal issues related to the decision-making process. In our experience, we manage the allocation of resources through a collaboration. So we set up a planning and a system together with the emergency department and our colleague in medicine. I didn't say that into my presentation, but the medical unit provided majority of non-invasive ventilation. Anesthesia stopped the elective lists, and we were focusing mainly on invasive ventilation. Criteria we used, and I can share with you our toolkit, were related to the possibility that the patient had to reverse the disease. Clearly, if a patient was COVID positive with a background of chronic disease, even if the severity was not extremely high, we knew that 2-3 weeks, because this is the course of the disease of intensive care, will not allow him to have a proper recovery. So we took into the criteria severity of the disease, but we combine it with several other elements. I think a lot of the criticism came through the fact that several centers look at age as one of the limiting factors. But I think as the disease evolved, we consider more chronic diseases and frailty of the patients. And we realized that actually, and we are now working on a systematic review, the mortality for patients, regardless the age, that require intubation is higher than half of them. So, it was a hard call to make, especially at the beginning, and especially where we didn't know what was about. Regarding the protocol, there's a difference between devices and medication. As I mentioned, we were lucky enough to set up a multidisciplinary team. So either the patient was included in a randomized study, or it was discussed in the multidisciplinary team that was able to follow up those cases in the long term. And maybe we can have also a discussion about it when we will talk about steroids, because as I understand, Lorenzo is very keen in the use of this drug. My personal concern, and what we are working with this group, is that if the patient goes home, or if the patient lives in intensive care, cannot be on a long-term steroids, and how do we follow them up, and how do we make sure that no complication in the long term will be present in this population. I hope I replied to your question, which was quite
it was very
complex.
Long. Yeah, sorry. Okay, we can continue with Dr. Bo.
Concerning to our response in the acute phase, you asked us, if I understood correctly, how we did increase the ICU beds, and I saw in the presentation of our colleague that we reacted in a very similar way. We tried to get as many ventilators as we could, but actually there were also unavailable on the market. So we, in an initial phase, when we opened the emergency ICUs that we mentioned before, actually we used operating room ventilators in a transitory phase. So at the end, the hospital managed to acquire more ICU ventilators, which of course performed better. But we had a couple of weeks with at least 12 patients intubated in the OR with OR ventilators. And this is pretty much the experience of most of the Italian centers. And also Francesca raised another relevant issue, which was of crucial importance, at least in the most hit regions of our country, which is triage, namely how we select patients to be admitted to the ICU. Francesca mentioned a document of our National Society of Anesthesia, which was highly criticized. I will not enter into the dispute, but for sure this guideline gave the public opinion the message that the system was under great stress, because it is true that is part of any intensivist life, choosing the right patient to admit to the ICU to better allocate the resources. But we cannot hide behind ourselves, and we must admit that in this emergency we had to change the way we did triage. I don't see any reason to minimize this fact. And actually, we took into consideration several factors, including comorbidities and age, and we did our best to allocate the resources. But as we mentioned before, this was more similar to a war scenario in which the choices had to be made quickly and with very low availability of resources. In the most terrible days in our hospital, and our hospital is not one of the worst hospitals in Italy in terms of COVID emergency. We had up to 4 intubated patients in the emergency department connected to temporary ventilators, for example, transport ventilators that usually are used only to take the patient from one place to another, and that they were waiting the place in the ICU. And in many cases, we used non-invasive support just as a bridge to intubation, because we could not intubate all the patients we wanted to intubate. I think that at least between us and between colleagues, we must be very honest on the challenges we faced, because this was an unprecedented stress for us. And I will conclude responding to your first question, why there was a lack of common guidelines. Guidelines are based on evidence, and we did not have any kind of evidence. And we did not have the energies to develop high quality evidence. So for a doctor and a researcher, which I'm both, it was a disaster, because I felt unable to treat the patient as much as I would have wanted to. And also I realized that the level of care we were providing was not based on evidence, which is a real pain for someone that usually loves making research.
Thank you. Now, Dr. Demirkiran.
Okay, and I'll start with how we increase the ICU beds. As I mentioned in my presentation, we changed the theater as an ICU, and we increased ICU beds double times in Cerrahpaşa, and we had enough ventilators, ICU ventilators, and we used them. And in 2 or 3 days, we were shocked, because the patients increased very fast in our ICU. In a few days, we had more than 30 patients in intensive care unit as COVID virus pneumonia disease. And as you can understand that intensivists cannot do this by their own, and we need help, and the anesthesiology department help us. The anesthesiology residents shifted in our intensive care unit for 12-hour periods, and they support us, and we had enough human power in our intensive care unit for doctors. As nurses, the nurses supported by the other services, and they came to intensive care unit to work as an intensive care nurses. And we had our protocol in Cerrahpaşa, and as Lorenzo said, the protocol is not stabilized. When we started the first days, now we changed the protocol because there is no evidence. Every treatment has different effects, and you see the papers. We read the papers. Recently said the hydroxychloroquine is not effective, and then we have to change our protocol. And we use immune plasma in our patients and TOSI in our patients, depend on the severity, and also stem cell. We use stem cell therapy in our few patients. And you ask ECMO, as I told before, we use ECMO in our cases. We start with the non-invasive techniques like nasal high flow, non-invasive ventilation, or helmet ventilation. When they were not enough for treatment, then we intubate the patient and start the ventilation, because we try to intubate the patient not earlier that time, a little bit late, because when they intubated, they become worse. We had to use prone position very often for this patient in our intensive care unit. And also we add, as Rubulotta said, anticoagulation therapy in our protocol, because the coagulation is a very important part in COVID virus infection.
Thank you so much. So in extension to this question, I would like to know, when did we realize that coagulation was a problem for a COVID patient? And also I would like to know, because as far as I know, in our hospital in Cerrahpaşa, we use tocilizumab very often. I mean, often enough. And I know that in University of Genoa Hospital, Dr. Bo uses steroids and thinks steroids could be better in terms of, he will explain it better. And I know that anakinra is more commonly used at Imperial College. So could you please share your experience based on these subjects? Dr. Rubulotta, can we start with you, please?
So first question was when I noticed that patients with COVID were coagulopathic, correct?
Yes.
And that was the first time I spoke to Lorenzo. I didn't know before. And then what we did, we raised this trial group, and we decided before treatment to understand what we wanted for these patients. So we, as I said at the beginning, we set up a pathway, and we set up standard lab, which included D-dimers and coagulation. Where we could, we started doing thromboelastogram. And then after that, we decided about the treatment. We are a neurosurgical center. And in the last month and a half, we realized that patients can come to our center with stroke. And the cause of it is COVID related. We are serious, so we have a small case series of patients that were a little bit older, so between 70 and 80, that were treated in our clinic, and they are now follow-up home. They never made to intensive care, but they developed different degrees of stroke. We got a small case series of patients that came with a thrombolysis call, and they undergo a thrombectomy with all the challenge of anesthetizing a patient for a thrombectomy. And I will invite you actually to look to the SNAC Neuro guidelines for the management of these cases, which are really well written by Deepak Sharma. And so we face this, and now we have created a small committee. There's been discussion whether we wanted actually to divide the committee that we use for all the drugs from the committee that looks at coagulation. And we came to the conclusion that we should keep the two together, even if we should discuss some special cases in a different setting. And among those special cases, definitely we have to talk about our stroke calls. And anticoagulation is at the moment considered completely different if the patient has thrombolysis before a thrombectomy, if the patient has infected the posterior versus the anterior territory, and cases with a posterior territory infarct did very poorly, I'm afraid. And most importantly, now at Imperial, we develop a fast test that can give us the result of the COVID positivity within hours. And we found this is really important because clearly a young patient that comes with a good outcome, potential outcome stroke in the front territory and get a thrombectomy, the anticoagulation after the thrombectomy, if he has not received thrombolysis, is impacted whether he is a COVID positive or a COVID negative patient. And we need to have the response for this subgroup quite quickly. Regarding the other questions, which was related to the tocilizumab and the anakinra, is not true that we are using one more than the other. We just concluded a trial called the COVACTA trial, so we're waiting for the results. We used the two drugs in a similar incidence. We have 46 cases that we are now reviewing, and we used anticoagulation in all of those cases, which I think is a quite important element, because obviously combination of therapy might be more powerful than just a single therapy. We have a trial, which is an adaptive trial looking at the use of plasma. And I think it's important, and I probably didn't say that at the beginning, we never use hydroxychloroquine, and we never used hydroxychloroquine from the start. And we are now seeing that the results of the studies are not so positive as we expected at the beginning. So as a group, we are continuing not to use it in severe cases. There's still some discussion whether we should use it in the community, but I don't know the answer.
Thanks. Thank you. And Dr. Ball?
Well, concerning coagulation, actually, we were in a condition a bit different from other countries because, again, we were the first. So I think that most northern Italian centers, the most hit areas, proceeded in parallel with clinical reasoning. And so I think that most of us came to the same conclusion at more or less the same time. But we were in contact, of course, with our colleagues in Lombardy, which started to treat ICU COVID patients a couple of weeks before we did. And actually, they told us a lot of precious suggestions, but in particular, if the question is coagulation, if you want an answer on how we realized it, is that at first sight, the coagulation of these patients is pretty normal, seen on routine coagulation testing exams. The only thing that is typically altered is the D-dimer, but at first sight we interpreted this just as an inflammatory response. I remember one night that I was performing a blood test analysis in one patient which was already receiving intravenous heparin, and the blood coagulated in the blood gas analysis syringe in the short time from the patient to the blood gas analyzer. And I said, oh, what's going on? I took another sample and the second one coagulated again. So the day after, I said to myself, okay, there's the dimer alteration, there's a tendency to coagulation despite heparin, there's something strange. And then we started discussing among us and with the colleagues from other centers. And we are happy if some other center can benefit of this experience, because actually the weeks after the first papers from China were published, so we were not the first in noticing the alteration of the dimer and coagulation in these patients, but we were not aware of this because we didn't have data from China because before the publication of the first papers. So really we had to react so quickly that most of us worked like blinded, without references, without guidelines. It was really difficult. Concerning tocilizumab and steroids, it's not correct that we did not use tocilizumab. We used it in several cases. We usually discussed the indication with the infectivologists based on our perceived risk of developing more severe disease or in severe cases. The reason why I'm so enthusiastic about steroids, and I can't wait for strong evidence to be published because that's what we need. I'm not saying that steroids are better than tocilizumab. What I say is that the ICU is the right place where to think about COVID, but it's not the right place to treat patients. We must treat the patient earlier before they come to the ICU. And we need cheap drugs. We need drugs that can be administered at home. And tocilizumab is not cheap and not easily administrable at home. So I hope that steroids work because there's no evidence. I'm not saying they work. I hope they work because if steroids, especially short courses of a few days of steroids in the early phase, if they work, this could be a major advantage for treating own patients also in low income countries, because we must remember that this is a pandemic. So countries of any economical development degree are involved in this.
Exactly. Thank you so much. And Dr. Demirkiran, could you share your experience with us?
Yes, okay. We are also take care with the coagulation, and we use anticoagulation therapy in our COVID virus infection patients. We use enoxaparin for them, and we add also dipridamole in our cases, and we daily screen the coagulation lab results for the to see the effect of the anticoagulants in our patients. About tocilizumab, in severe cases we use tocilizumab, and we follow the effects of the tocil in our patients, but we aware to have secondary bacterial infections in that cases also. And when we talk about steroid, we use steroids also in our cases. Methylprednisolone, we use methylprednisolone in our COVID virus intensive care critical ill patients.
Thank you so much. So now we can continue with the next question. It was a long question, sorry for that. So I wonder, how did you manage COVID-19 negative ICU patients? Because we had to invest all of our beds, ICU beds, to those infected with COVID-19. What did you do to those patients in need for ICU but didn't have the disease? And also, I will ask the extension in the next question. So we can start with you, Dr. Rubulotta.
So that was a big challenge, and I think we have not solved the problem yet. Mortality curve in England is much higher this month compared to the last 5 years, and the death rate is not related only to COVID. So definitely there is a big component represented by people that could not receive the treatment needed or could not come to hospital because of high risk. We had some strategies in place. One was partnership with private hospitals, where the elective surgery was stopped, and we were aiming to use their facilities for trauma transplant and cancer cases. The difficulties there were related once again with testing of the patients and of the staff. Because clearly, if you have clear hospital, you need to have also clean staff and organize the work in shift. We then tried to organize teams within the same hospital, but that was once again challenging. It's becoming now easier because we have faster, more sensitive, and more efficient tests. At the peak of the pandemic, 2 big centers were open in England, one outside London in the Excel Center and one near Birmingham. And those could accommodate thousands of COVID patients. And the strategy was to centralize the care and reopen part of the hospital for emergency care. The reality is that we never managed to distinguish the two groups. And now we are in a phase where we have closed those big 2 centers. We have selected and redivided our intensive care with a COVID and a non-COVID bay. And starting from next week, we will start what we call P1 and P2 type of surgery, which is emergency. And we plan probably by July to start what we call P3 and P4 surgery, which is less urgent. And once again, we're now testing more in the community, and we are planning to test the staff and try to divide the 2 groups and make them working in team. There is some evidence in China that working in team under pressure has also other benefits. So we want to get the 2 things together.
Okay,
if possible.
Thank you so much. And Dr. Bo?
Thank you for this important question. We experienced also in our case an increase in mortality also related not directly to COVID. I would like to share a slide that I partially showed you before. And first of all, just to give you an idea of the proportion of the emergency in our hospital, which again is not one of the worst hit areas in Italy. This line is made up of ambulances directed to the respiratory triage area of the hospital in one of our worst nights. You can see a row of several ambulances waiting to be tested for COVID, and many of these patients were later admitted to the ICU. In this slide, I showed you how we increased the COVID beds, and as you can see, all the units marked in black are units that were dedicated to COVID negative patients. And we managed to keep the things separate quite well, I think, because we never really stopped all the surgeries because we are an oncologic center. So we decided to continue at least urgent oncological surgeries, urgent in the sense of oncologically urgent surgeries. And we managed now, since this week, to restart also general elective surgery. So, so far we are performing well, but it's really a challenge because it's enough having one missed positive case that you risk to contaminate several other patients and the staff as well.
Thank you so much, and also for the image. I hope we passed those nights. And Dr. Demirkiran?
In our hospital, at the beginning, we organized to divide ICUs, COVID and non-COVID. And we separated all doctors, nurses, and medical staff from COVID or non-COVID, and they not contact each other. And we have non-COVID patients in non-COVID area and the others in COVID area, because still we have patients, critically ill patients who needs intensive care, but they are non-COVID. And we stopped the elective surgeries, just the emergency cases had operation and anesthesia. But this week, UK and Italy, we restart again for the elective surgeries, not all, but part by part, we start for the elective surgeries.
Okay, thank you so much. And the other question is actually from one of our audience. He wonders, like 2 episodes before of this CTF Talks events, one of our professors suggested that there were some people that were completely healthy, had no comorbidities, didn't smoke at all, but have severe COVID disease. So how do we explain this? We really need your opinion on this. Dr. Rubulotta?
$1 million question, so I'm clearly. So the last information we have from England is that, I mean, all the discussion at the moment is about what is next step and whether it's safe or not to open schools. And the data we have for the country is that we have 30,000 deaths, roughly. And among these 30,000, 30 people were between the age of 20 and 40, completely healthy, and most likely they were infected through their kids and they died. I mean, 30 over 30,000 is a small number, but it's a lot, especially if you're 20 years old and you're otherwise healthy. I do not believe that the reason was the pressure on the health system, because even at the peak of the pandemic, we were very lucky. We had enough resources. So I think there was space to care for these individuals. But we should say that there is a range. The disease has very different onset. The presentation, the initial presentation is extremely variable. We do not know enough about this. And if I may say so, one of the limitations, I believe, will impact lots of the trial we are doing is that it's very hard to understand what is time zero, because we don't know when the disease started, how it started, compared to when they arrived to the ICU. So my answer is that, yeah, the majority has a now more predictable trajectory, but still there are the 2 ranges of presentation that we do not know, I do not control very well, and we need to take into account.
Thank you so much. Dr. Bo.
Well, first of all, I would like to underline that as doctor and also as men and women of science, we must first of all say that we don't know many things about this disease. So the correct answer to your question is we don't know. I would like also to invite you to think about the fact that yes, there are atypical severe cases in younger people without comorbidities, but that the prevalence of the disease in certain areas of the world is extremely high. So we are seeing a very small percentage of probably unlucky patients that developed in an unexplained way a severe form of the disease. This is not different from what we see in our regular clinical activity when we see, for example, a very young patient that develops a cancer that typically develops in the older age. That happens because of the large numbers. The difference is that now we are seeing large numbers in a very short period of time. So each case with the abnormalities raises a lot of questions, and people ask why a young child contracted the severe form. We don't know why some people under the age of 40 die. We don't know, and there are open questions. Some of them will find an answer through research, and in some other cases we must also surrender to the fact that some of these answers will never be found.
Thank you so much. Dr. Demirkiran?
As Dr. Bol said, we don't know exactly what's going on with this disease, with this virus, because it has changed patient by patient. In young patient with no comorbidity, it's gonna be very severe disease, and we were surprised with this. How can we manage it? Why we couldn't give enough cure for these cases? It depends. It depends something different than we know yet. Maybe in future there will be more explanation about these.
Thank you again. So finally, before we close the first part, I know it was very long, and thank you for your attention and for giving your keen interest and time. I would like to ask, how often healthcare workers in your hospital or area were screened for possible COVID-19 positivity? And what kind of modality did you prefer? Dr. Rubulotta?
So the indication changed over time, and probably this is the same experience in other centers. At the beginning, even the WHO suggested that we should be in screen only if we were symptomatic, or we should isolate only if any of the people in our home was symptomatic. So at the beginning, in February, March, the top of the spread, only people with fever and cough were effectively screened using the swab. And we managed mid of March to develop our own system, so we didn't need to send the tests outside our hospital. So we reduced the time from 3 days to 12 hours. In middle of April, we managed as Imperial College to develop our fast tests, but we have very few of those, and we need to share between the staff and the patients. I think at the moment of this very rapid one, we have only 25 per day. So, and the indication for screening are becoming much more inclusive, especially in the view of opening up the hospital to more elective procedures.
Exactly. Thank you so much. Dr. Bo?
Well, we behaved quite similarly also, because these were the official recommendations of the WHO, which probably underestimated initially the possibility of transmission to the healthcare personnel. Our hospital decided, as far as I remember, in mid-April to do a mass screening of the personnel, but based on antibodies, which are not the gold standard. But because our labs could not afford performing to all the healthcare personnel so many nasal swabs, because we were already overloaded by the clinical activity. But actually, at the end, we did the screening with antibodies, and now we also did the nasal swab. And I'm very happy to say that in our ICU, in which between doctors, residents, and nurses, we are 150 healthcare workers, none of us got infected. We had 3 cases, but they were infected at home by relatives. We had no cases. Unfortunately, we had cases in non-COVID areas, which paradoxically are the most dangerous, because healthcare personnel is not aware of the fact that the patient might be positive.
Thank you so much. Dr. Demirkiran?
At the beginning, only who have the symptoms were screened, and now all ICU staff screened for COVID virus, like Bol said, Dr. Bol said, nasal and pharyngeal swabs.
Okay, thank you. Now we will give 5 minutes of break. Then we will begin our part 2, which will be a little shorter than the first part, hopefully. Okay. Hello again. Now we are here for the part 2, and I would like to thank you on behalf of our CTF Talks team that we received incredibly wonderful comments on the YouTube, and thank you for that. And we will try to continue to ask your questions as follows. So the number one question in the part 2, which we'll discuss more about on the paramedical issues surrounding the COVID-19 period. So do you think your country have enough critical care specialists? And since we are now listened by lots of medical students, what can we do to promote anesthesiology and intensive care as a specialty among medical students? Dr. Rubulotta.
So thank you for these questions. I'm very passionate about promoting intensive care, but we need to keep in mind that there's a difference across country. The specialty can be combined or can be completely different, and they were both needed in the course of this pandemic, so they're equally important. I think that the big gain is that public opinion learned about intensive care. So lots of the media, a lot of information made people aware of the importance of this work that has been for many, many years undervalued and mostly unknown. I do believe it is a fascinating field. One of the limitations of working in intensive care is the work-life balance. And this is something that didn't come well across during the pandemic, because obviously we went through a very, very difficult time. So I think if we can combine the exciting results, the importance that the specialties are having now on the media, and maybe we plan a more suitable work-life balance for the trainee, I'm not aware of any specialty that can be so inclusive, technological, innovative, and exciting as much as anesthesia and intensive care.
Thank you so much. Dr. Ball?
So also in our case, this emergency gave a lot of attention towards anesthesia and intensive care in general, and intensivists in Italy had a leading role in handling the pandemic. So I think that this might raise the interest towards our discipline, and we are now trying to understand how to reshape the training, because it will be challenging in the next future. So far, lectures are held online, but of course medical training requires practical skills that cannot be replaced by online lectures. So we will see in the next weeks and in the next months how to deal with this challenge.
Thank you so much. Dr. Demirkiran?
Yes, the question is, do we have enough critical care specialists in our country? As Rubulotta said, the critical care was unknown in also like the other countries, but now with the COVID virus attack, the people and the other doctors, specialists understand the importance of the critical care. And in Turkey, critical care is a super specialty. I mean, like the others. And the critical care, if you look at the history of the critical care in Turkey, it was started by anesthesiologists in 1978. The first Turkish Society of Intensive Care, founded in 1978. It's very close to the European Society of Intensive Care Medicine Foundation. I want to explain that it was started by anesthesiologists in that time, and also most of the people don't know the anesthesiologists manage the critical cares, but now they understood that. In our country, the anesthesiologists give a big support to critical care specialists in that COVID virus attack to help and to give care for the critical ill patients. And also the other specialties also have opportunity to be critical care specialists. We work all together in critical care units, and I recommend to medical students to be intensivists because intensive care is a huge knowledge. You have to know everything. If you want to use your brain to be an intensivist.
Thank you so much. Can you hear my voice, by the way?
Yes.
Okay. There was a lack of voice there. Okay, now the next question. With this pandemic, we realized that we must be ready for a possible next pandemic more than ever. And in order to be able to better act in the next pandemic, we need a well-trained doctors, healthcare workers, etc. So how do you think the core curriculum of medical students will change in the future? I mean, what can we change in the core curriculum to better train our medical students in the field of pandemic? And Dr. Rubulotta?
So in the course of this pandemic, everyone was at any minimal exposure to intensive care has been redeployed to work with us. And we organize training and simulation very fast for make them able to help, to communicate effectively, and to manage and troubleshoot through emergency. I do believe that the learning that we provided here was very pragmatic and related to a systematic approach towards the ward rounds, where essentially non-intensivists were still able to assess the patients from A, B, C, D perspective, and to call for help when help was needed, more than manage the situation in isolation. When the ratio was 1:40, clearly we could not even do a proper ward round. So we need to rely on the nurse experience and on the doctor experience, junior doctor experience. I think most of our trainees found that unique, exciting. Obviously, I do not believe that any of the college in England will want to change the curriculum to address intensive care specific competencies. I'm not sure about that. The real concern that we have now here is that, as mentioned, the training across England is competence-based. And most of the things that those people have done in these 3 months are not part of their core curriculum. And now they're worried about the time needed to complete and tick all the boxes for their mother specialty. As I said, I think that disaster management and systematic assessment of deteriorating patient is something that everyone needs to know working in a hospital. I think modern medicine is moving more and more towards silos, where you are super specialist in one field and we miss knowledge on critical care. And this has been reported many times as the main cause of deterioration of patients on a normal condition in the world. I do not expect the core curriculum to change, but I expect the awareness of critical illness to change, and the knowledge of this generation is definitely different from the generation before.
Thank you so much. Dr. Bo?
Well, I think that also in our case, trainees and residents were a key to our survival during the worst phase of the pandemic, because without them, the clinical activity would have been impossible. And from one side, as I said before, I'm happy of the fact that this emergency raised the interest towards our discipline. But on the other hand, I think that we must admit that the greatest lesson of this emergency is that intensive care is just an extreme solution, but the real key to success is prevention, early tracking of cases. So I think that it's more about changing the way the international organization collaborate to identify the potential sources of infection, instead of running to buying ventilators, because it's not the solution. We don't know which will be the next pandemic. Maybe it will be an hepatitis disease, and we will no longer need the ventilators but other machines. So I think that the key is understanding more diseases and not just running, reacting in a military way.
An astonishing point. Thank you. Dr. Demirkiran?
Okay. And maybe we have some changes in our practice and in our education field. The most important part, as Dr. Bol said, the prevention for infection is very important, and all must be aware to infection prevention, as like the Surviving Sepsis campaign and the awareness day for the sepsis, like that. We have to make some awareness days for or action to prevent any other infection and how to manage it, and also critical ill patient management, to learn how to manage a critical ill patient, and we learn how to use the non-invasive ventilation techniques like nasal high flow or helmet or CPAP ventilation also in emergency, before ICU and in ICU. And maybe we have to some important parts in our education and teaching lectures and sessions to implement that.
Thank you so much.
May I make a comment? I think
sure.
Yeah, no, I think I want to stress the importance of the comment that Lorenzo made, because obviously we cannot talk based on data. We have not the results, complete figure of what we've been doing over this period of time. But we should ask the question, not just how many people died, but what happened to quality indicator, what happened to the care we provide, and what happened to the patient that survive intensive care. Because what we're seeing now is a very high number of delirium, a very high number of critical illness neuropathy after 3 weeks of invasive ventilation. And we know by fact that we didn't provide the same quality of care that we provided before this pandemic. So I think the point that Lorenzo raised is really important. I'm not sure whether I can make a comment, but it's very wise to see whether we really invested our money in the right direction, or whether we should probably in the next pandemic think about a different strategy where intensive care is not the front line, but is only reserved for a small group that would really benefit from the time we spend, from the time and the work we do to understand the disease, and maybe can get a better outcome. Because I'm not sure we had excellent result regardless of the effort we put into this project so far. And I don't know what the other think about this.
Thank you so much. Any extra comments would you like to make? Okay, we can proceed to the next question then. Thank you, by the way, for this wonderful comment. Now, I would like to talk about healthcare worker burnout. This was not a new topic that was raised during this pandemic. We've been talking about this since quite a bit of time, but during this period, it was more visible to the people's eyes. So because we saw doctors committing suicide or sad things like this, and I give my deepest condolence to them. And also, what kind of support can we give to those healthcare workers in need? And what kind of modalities that you used during this pandemic? For example, did you use a psychological support to the staff in the ICU, or any other example that you may give? Dr. Rubulotta?
Yeah. So we have results, as I mentioned in the presentation, from an anxiety questionnaire that ran in 76 countries. And the results were interesting in the sense that anxiety in the front line was mostly related to lack of information, what we said before, lack of guidance, contradicting information, changing information, like, for instance, testing, who should be tested, when, and how. So all this level of uncertainty definitely contributed to increase anxiety among healthcare professionals in the findings of this research. I'm not sure about burnout. We're facing now post-traumatic distress due to a combination of workload and it's suffering, obviously, and we are managing with extra psychological support. We started at the end of March, might have been late, but that was the earliest we could provide online support, phone consultation, and even now we are having video conferencing on request for that those staff members that are in difficulties.
Thank you so much. Dr. Bo?
Well, concerning burnout, it has been for sure a problem. I think that the reason were several, among them for sure the extra workload, but not only. The world is changing under our eyes, and healthcare workers are humans, first of all, and so they have fears, and some of their fears are also related to the fact that as doctors we are trained to deal with other people suffering. We are trained to deal with death, but we are not used to pose our own lives at risk, which is something we really were afraid of at the beginning, especially when then after weeks we realized that with sufficient protective equipment the risk was probably not as high as we imagined. But the first weeks we were all really scared. We were scared of carrying the disease at home to infect our relatives, and so this is something that really has shocked some of us.
Thank you so much. Dr. Demirkiran?
Yes, burnout is a very severe problem in the medical staff, and workload is also a problem. The stress of uncertainty of health, livelihood, and duration makes a big impact to the productivity of the teams, and they need support. My personal believing is that they need support by a speech therapy with the psychologist is very helpful for them, and they need more resting times. And we try to improve their resting times, and we try to support them with some small facilities like some good meals or some presents, some chocolates, some good drinks or something like that. We have to improve the personal feelings to have to feel themselves good during the day.
Thank you so much. So, and a last question will be about the next era, a post-COVID-19 era. First of all, many of our audiences wonders if we will see another peak, a second wave in the course of this COVID-19, and also we would like to know how the normalization will be in your country from your eyes, from your perspective. What do you expect to see? Dr. Rubulotta?
Thank you for the question. As you said, we are not, I mean, we can see a light at the end of the tunnel, but we should not forget we are still in the tunnel. So, and this is a completely new disease, and all we estimate is based on assumption. So some of the prediction that we will do in phase 2 or phase 3 might be wrong, and this might reflect another peak, smaller or bigger. And as Lorenzo said before, and we don't know why some countries were more lucky than others, and why the disease affected, or we can make assumption, but we're not 100% sure about the way the disease affected one country more compared to another. So I'm definitely positive. I still will not say that we should think about next era. We should still concentrate on this current era. And we've been talking for long about flattening the curve of this disease, but we are not talking about increasing the resources for the non-COVID emergency. At the same time, we're flattening the curve of this disease, because we shouldn't underestimate the number of people dying for non-COVID reasons. And probably these people will need more clinic, will need more appointment, will need access to surgery that has been delayed for months for them. So I think as much as we should stay alert, as our Prime Minister say in England, for reducing and flattening the curve, we should stay also prepared for providing more care for non-COVID cases that suffered during this time. Regarding training, the future is difficult. Regarding research, the future is difficult. We've been in standby for several months, and I hope really that we will be able to provide the required education in a sustainable manner. I hope that we reopen the labs and provide career opportunities to all the juniors that have served, worked hard, put their life at risk, and now probably deserve having something back in terms of career and progression.
Thank you so much. Dr. Bo?
Well, I totally agree with Francesca. I think we should focus on the current time rather than imagining the future, because there are several things we don't know, and even less we can forecast how the future will be. I think that we should be somehow optimistic. I cannot forecast whether a second wave will be behind the corner, but for sure it has never happened in the human history that such a huge effort in terms of economical and not only economical resources are all concentrated on one problem that affects the whole world. So let this be an opportunity to strengthen our international collaborations. And we never mentioned the potential solution coming from a vaccine in this entire session. I think there is room for hoping that a vaccine can be developed in the next future. Never a vaccine was so intensely searched for as in these months by all the world together. So let's try to be positive for the future.
Yeah, we will try to be. Thank you so much. And Dr. Demirkiran?
In my opinion, everything will be changed in the future. The timeline will be divided to two parts, BC and AC, before coronavirus and after coronavirus. And because the rules will be changed, the flying rules will be changed, the holiday rules will be changed, the shopping rules will be changed. We will keep the social distance. We have to do this. And surprisingly, the hand washing percentages will be increased. and also we will use more disinfectant, hand disinfection in the future. But still we have time to say that the coronavirus is stopped. I think we still, as Rubulotta said, we are still in the tunnel. Maybe we see the light, but we will not reach it. We will not reach the light. I think soon we have time for this, and we have to take care to prevent the second wave. And we have to be aware, still aware for the virus attack also.
Thank you so much. I know I said that this was the last question, but I have a very interesting question from the audience, and this will be the last, I promise. Okay. So our audience would like to know what has changed in your ordinary life. I mean, they would like to know your personal opinion on how is life now and before. Could you just describe it briefly, Dr. Rubulotta?
I was life now and before. Well, I'm not sure we are having a normal life at the moment. I bet no one can consider this as the life we expect we will have in the after coronavirus, in the AC time. So we still hope that it will get better. Is this a personal reflection to close the webinar, or is it a scientific questions, first of all? Because if it's the conclusion, it's quite late. I might move to more personal comments, and I don't know whether it's this the topic of your questions. Personally, I believe that some positive might come from the experience. More collaboration definitely has occurred within the hospital, more understanding of each other needs. Lot of the things that were relevant before, such as flying and moving, have been bypassed by technology. And I think we're becoming more pragmatic to what isn't important. And I hope that this will stay in the AC time. Definitely I hope to have a more normal life, and maintaining some rules is pleasant. Reducing the cars, London has never looked so beautiful before, but definitely I'm missing normality.
Thank you. Dr. Ball?
Well, actually, we are still at the beginning of the so-called phase 2. So actually, we barely remember our lives before, because even if it was only 3 months, things have changed radically. In Italy, we experienced a very prolonged lockdown. We couldn't do anything else but working and being at home, with no exception at all. So definitely it was a major change. But let's try to focus again on the future. And also in Italy, we were also starting to face severe economical consequences. But let's think also about the fact that in human history, every big crisis have been followed by a resurgency phases. So let's try to think in this way.
Thank you so much. Dr. Demirkiran?
I gave this answer personally, and we missed our friends, we missed our hobbies, and we missed our lovers and families. And I missed to fly because for 3 months I couldn't have any flight. And I hope it will be finished soon and we will fly, and to be a normal a little bit. We need this now, because we work very hard, and all of us are tired because of this virus infection.
Thank you so much. Now our part 2 is finished. Don't be so worried. But a funny question just asked by one of our audiences, specifically to Dr. Rubulotta. How did you protect Her Majesty the Queen?
Well, my short answer is that we were so worried about the majesty that we forgot the prime minister and we almost missed him. And having said that, I have a 95 years old grandma that's doing very well. So I can assume I brought my Mediterranean expertise into the into the game.
Yeah, you did.
But yeah, as they say in Italy, stay home and stay safe. And I think the Queen did it quite well.
Thank you so much. Now, a special note I have to tell you that from CTF Talks team, this meeting and CTF Talks team are a student organization, and we're trying to be better. And with this meeting, with this session, you helped us grow, and you taught us a lot of things from this session. And with your beautiful help, we hope to become better in the future and try to discuss lots of science through this channel. And for me personally, I'd like to thank our beautiful guests. They were very helpful throughout the process. I was very nervous at the beginning, like my mouth was shaking. But at the moment that I've met them, I saw a very polite and warm personage. So thanks again for being wonderful. And a special thanks to CTF Talks team, who gave me the chance to moderate this event. It was an exceptional experience, and I'm very grateful to them. And good night, and thank you for your attention and keen interest on this session. Thank you.
Thank you.